Good afternoon and welcome back to session number 5. I'm sure you had a delicious lunch and ready to join us once again. So before we go on to session 5 of track 1, it gives me great pleasure to introduce the moderator for this session. He is Dr. Tariq Qasim, consultant psychiatrist, older adults, Maudsley, United Arab Emirates. Over to you, Dr. Tariq Qasim, the moderator for this session.
Thank you very much. Good afternoon, everyone. It gives me great pleasure to introduce Dr. Jigna Stott, who joined the Maudsley Team Health as a consultant psychiatrist from the UK. Dr. Stott has dual accreditation for older adult psychiatry and general adult psychiatry, and she has endorsement in liaison psychiatry. She graduated from Royal London School of Medicine and Dentistry, and then she pursued her training in psychiatry. She has completed masters in psychiatry, postgraduate degree in general practice, as well as postgraduate degree in medical education, in addition to being a full member of the Royal College of Psychiatrists. Dr. Stott has vast experience in dealing with psychotic disorder, mood disorder, anxiety disorder, chronic fatigue syndrome, and medically unexplained symptoms, in addition to working with older adults. Dr. Stott has a keen interest in medical education, and she has completed a few projects. She had founded the communication skill teaching program for medical students, and she also worked closely with the Royal College of Psychiatrists to promote mental health, and that led to a research project in conjunction with Health Education England. So please welcome with me Dr. Stott, who will be talking to us today about COVID-19, my patient and me, how COVID-19 is changing the faces of inpatient psychiatry.
Good afternoon, everybody. Sorry for that slight little blip there. I'm Jigna Stott. Today I'm going to be talking about two case studies of two patients who I saw whilst I was an inpatient consultant in the UK. And just to give you a little brief guideline as to how mental health services work in the UK, when a person is admitted to a ward, it's generally either under a section of the Mental Health Act or informally. Those who are admitted under section of the Mental Health Act are detained against their will, who lack capacity. There are two options. They can either be admitted for 28 days for assessment or 6 months for treatment. I'm going to be talking about two patients. So we're going to look at two patients. We're going to discuss their progressive symptoms, also discuss their risk factors, and also think about the impact on COVID-19 on mental health and the global implications. So case one is Mr. X. So he's a 44-year-old man, didn't have any previous input with mental health services, didn't have any mental health problems, fit and well physically, and works as a joiner. His wife is a nurse and they have 3 children. So absolutely no problems prior to working in services. So due to lockdown, Mr. X was unable to work as a joiner. All of those services were stopped. He was therefore the main caregiver for his children. He was also in charge of homeschooling. This was a quite unusual situation for him and was therefore a little bit difficult. His wife was still going into hospital as a nurse. There was increased stresses because early on in the pandemic, there was a difficulty with knowing what was going to happen, what the coronavirus was going to produce and what was going to happen. He developed some anxiety and some worries due to education, due to how lockdown was going to progress and how things were going to happen. So he presented to the emergency mental health team. He was agitated at the time. He had some thoughts around something terrible happening. He wasn't sure about, he wasn't able to articulate what he was thinking or how he was feeling. He reported about things being his fault, but wasn't able to talk about what these things were. At the time, it was decided out of his arm and had also attempted to start biting the other arm. The ward team were alerted by another patient and they were able to stop him biting the other arm. He was very distressed. At the time, he was unable to tell us why he bit his arm, why he'd caused that injury to himself. And wasn't able to stop being distressed. We brought down his level of distress and was transferred to a surgical ward as an acute emergency to receive help for his physical illness. He was also escorted by 2 psychiatric nurses who were monitoring him and keeping him calm, and also monitoring medication. We medicated him with a combination of antipsychotics and antidepressants, which was quite helpful. However, as the treatment progressed, his psychotic features emerged. He was suspicious of the nurses who were escorting him. He had various suspicions. For example, he had his mobile phone, which he contacted his wife with. At times, he believed it to be a bomb. He had a lot of paranoid ideas whilst on the surgical ward. He was treated whilst on the surgical ward while receiving surgical treatment, and his symptoms slowly abated. The resolution of all his psychotic symptoms occurred within about 3 weeks' time. His anxiety remained, but he had good insight into his situation. At that point, the antipsychotics were stopped and the antidepressants were continued. So we'll just move on to case number 2, Mr. Y. This is a 62-year-old man on the same ward. Again, no previous mental health difficulties, no family history of mental health difficulties. He was out of work due to COVID-19. The difference for him was that he had been alcohol excess for a number of years, for many years, and this had increased since lockdown. He's a man who lived alone, very, very small social circle, and due to losing his job, he needed to organise emergency financial support, which was there in the UK, but it was something he needed to apply for and go through filling a number of forms, etc. He was also the main carer for his elderly mother who lived nearby. He did her shopping and visited daily and looked after her. He told us he found this quite stressful because he wasn't sure whether it was the right thing to do, whether it was still safe for his mother to receive him, but he felt that it was something that he still needed to do. He was brought to mental health services by the police. The event was that Mr. Y had dragged his mother outside of the house and had thrown her to the ground. He proceeded to go home and leave her there. She was found by a neighbour eventually the next morning and was taken into hospital. She was found to have a dislocated shoulder, fracture of the forearm. That's why the police were alerted and taken and sent to his house. He was brought into hospital and was interviewed by myself. And he reported initially that he was worried about his own safety. He talked about hearing his mother giggling, talking about the virus, making him a cup of tea. He thought that perhaps the tea was poisoned. it came to his mind that perhaps his mother was possessed by a demon and therefore wanted to kill him. He was scared for his life, and he said he did what he did. He wasn't able to explain the step-by-step process, and I don't think he really remembered or understood it himself at the time. He presented as being guarded. He was unsure what to believe. He looked perplexed. He was talking about the coronavirus being a plague, asking the team whether it was the end of the world and what he should do. Again, with the previous patient, we treated him with antipsychotics, and due to his history of alcohol excess, we did a full physical workup and found no abnormalities. This gentleman's recovery was quite quick. His psychotic symptoms resolved within about 3 days. There were some feelings of guilt around his behaviour. And he had variable insight into the situation. He still believed that his drinking excess wasn't a problem. He had little insight into his mother's aftercare, and also about further interviews with the police and about whether he would be charged or interviewed for the incident. So just looking at both of the cases side by side and having a look at some of the risk factors and learning points. So the common risk factors for both of these cases was the COVID lockdown, the strict lockdown and reduced physical social contact, the loss of role. Both patients lost their jobs and their usual routine. Both patients also expressed an anxiety and also a fear for life. The common symptoms seem to show paranoid thoughts, guardedness, abnormal perceptions, voices in the case of both patients. Both patients also performed extreme acts of violence, which were led by a fear for self. So if we look overall about the learning points and thoughts about these two cases, it seems that the global pandemic has raised anxieties in a lot of people, and it has led to an increase in mental health difficulties. Cases have presented in inpatient and outpatient settings, and the psychotic cases seem to have increased as described by our colleagues at Alamal yesterday have shown. It seems as though we shouldn't underestimate the risks of the anxiety dipping into psychosis and the usefulness of antipsychotics and how actually they're only required in the short term, and perhaps we should keep an eye on our patients and our prescribing. We also consider the wider problems, and will we continue to see mental health presentation? Will once the COVID crisis finishes, will we still see more patients present with perhaps depressive type symptoms, anxiety type symptoms, or continue to see psychotic symptoms? I think that also the bigger thing is also how can we continue to support our patients and manage the inevitable increase in numbers. Currently, we're hearing that patients who have suffered with COVID-19, 1 out of 5 of them will then go on to present with mental health difficulties. There's also the situation of long COVID, which is a chronic fatigue type syndrome, which is developed in patients who have had COVID-19. I think the current situation where we'll have to wait and see what does emerge next. But also I think it's about mental health services being a little bit more prepared for the unknown and perhaps the semi-predictable syndromes that are presenting. So I'd just like to say thank you for everyone in listening to my talk. I hope it stimulates some thoughts for the future and for future mental health services. Thank you.
Thank you, Dr. Stott, for the interesting case. It's very informative to know the experience in the UK, and I'm sure that we will have a lot of questions about experience in general, as well as those particular cases. Now, it gives me a great pleasure to introduce Mike Adams, who's OEB in the UK. Mike Adams is an executive director of CareTech Holding and CEO of Purple. Purple is an organization that aims to change the conversation about disability from welfare and charity to a value and contribution in the community. Purple aims to works with organizations with disability-related employment program, and it has been internationally recognized. They serve more than 5,000 organizations in the UK and beyond. Mike has an over 25 years experience in senior management roles, including education, drawing on his own disability. He has developed disability inclusion solutions for government, private sector, as well as public organization. Mike has been awarded from the Queen the honors of OEB in 2012. So please welcome with me, Mike Adams, who will be talking to us about the value of people with mental health in employment for both individual and employers, and how it can be done. Thank you.
Good morning, everyone, and I am delighted to be joining your conference today. The current COVID-19 pandemic has shone a very bright light on disability issues. From the United Nations report to data in the UK, all have shown that disability has become much more of an isolating issue, and disabled people have been disproportionately isolated during the pandemic. This is partly due to the digital world not being accessible, and that is a primary challenge. But the other key issue is the increase of people with determination who have mental health issues, and this is growing rapidly. And it is also a big issue for employers. And today I want to address the value, the positive contribution that people of determination with mental health can make. So, to set out the clear learning objectives of my presentation this morning, it's to understand a UK model of supporting people with mental health conditions into the workplace, and also for those individuals already in the workplace, how you provide better support. To understand the UK approach in supporting organisations to then recruit and retain people with mental health conditions. So how do we help employers? And to identify the key success factors to enable the model to be used in other countries, the principles to be used, and how it can be adapted by yourselves to make it work for your own context. So very briefly, who is Purple? We are a UK disability organisation, part of the CareTech group, who are absolutely changing the conversation for disabled people and business. And we believe that we are unique in that we provide solutions that support both people of determination and their parents and their carers through a whole range of training, support and coaching. But we also support organisations and businesses to build their disability confidence to recruit and retain disabled people. And one of the key points for us is that we see disability issues through the lens of both people of determination and employers. So the context, and it's incredibly important that we understand and we anchor in the context. And what we're talking about is the increase in mental health across the globe. And if we take the UK, for example, we know that approximately 1 in 4 people in the UK will experience some kind of mental health problem each year. We know that 1 in 5 women are reported to have mental health problems, and 1 in 8 men are reported to have mental health problems. And within England, we know that 1 in 6 people report experiencing a common mental health problem, such as anxiety or depression, in any given week. And we know that during the pandemic, the numbers have rapidly increased. And this is an issue for individuals, it's an issue for businesses, and it's an issue for government as well. So when we talk about mental health, we talk about behavioural problems such as depression, anxiety, and drug abuse. And they are reported to be the primary drivers of disability worldwide. And therefore, mental health is not unique to anyone in the UK, but is now becoming more and more prevalent worldwide. And studies show that people with mental health problems can get better and many recover completely. And so one of the dynamics with mental health that is different perhaps from other disabilities is that the conditions can fluctuate from day to day or week to week. And recovery refers to the process in which people are able to live, work, learn, and participate fully within their communities. And there is treatment for mental health issues, and that varies depending on the individual, but includes medication, therapy, or a combination of both. And what we know from evidence and research around the world is that employment plays an important role in the recovery process for individuals. So addressing this issue is good for the individual, is good and can be good for the organisation, and is good for families and the wider community. And so what I want to do now is set out a framework that we have developed through training to support people of determination with mental health conditions who are either entering the labour market for the first time or re-entering the labour market after acquiring a mental health condition. And the key components of this programme is that it provides up to 20 hours of direct contact with people with determination with mental health conditions. We like to, and we encourage, an element of work experience. It's good for the individual, and it's also good for the organisation to familiarise themselves with the issues, have some experience in a safe and controlled environment. And one of the key elements, key components, is that we blend the training methodology. Pre-COVID, it was a lot of classroom work. Increasingly, it's now virtual that works. And we provide one-to-one coaching and access to a whole range of resources. And I think what's really important for you to know is that this programme is appropriate for entry into all sectors and all industries, with organisations of all sizes as well. So in terms of the training content, we look first and foremost at managing barriers to work for people with mental health conditions. And that will include, for example, travelling into and out of work, which for some individuals who are anxious and nervous, travelling and going on buses and trains, etc., could add a real nervousness for them before they get to work or as they leave work. Then there is the physical access. And here I'm particularly talking about where the environment is busy, is noisy, and could provide, again, level of anxiousness for individuals. And then going back to what I said about COVID-19, there is the digital access. You know, to what extent is your intranet, to what extent is your website, to what extent are the devices that your staff will need to use online are they accessible? And in this context, we are particularly talking around color contrasts and font sizes and not having an overly cluttered web pages. But managing barriers to work is also about reflecting, and it's about understanding your own abilities, and given your mental health issues, understanding your restrictions and the areas where there is more development that is needed in order for you to maximize your potential. And it's also about understanding and managing the perception of colleagues, the people that you work with. And as I said, we explore all types of work, from office work, manual work, administrative activities, frontline activities, and also management. And it's about working with those individuals to develop their employability skills. And we do focus on CV writing and how you present yourself, because the first time you present yourself absolutely matters. But what sits behind of all of this is the ability and the need to develop confidence and resilience in individuals. And we particularly know that where an individual has recently acquired a mental health condition and needs the support to gain their confidence again to go back into the labour market. And alongside all of these issues is a need to tap into both motivation and well-being. But this programme is about outcomes. This programme is about supporting those individuals into jobs, into the labour market. And it is also about supporting organisations to look after and support those individuals so they are productive. And so we work with those individuals on interview skills and preparation for mock interviews, and then we run mock interviews, because for a lot of individuals, it might be the first time that they've ever had a work-related interview. But I think what's really important and what makes this work and what will help to make this work is the support that goes into employers and with employers. And by employers, I mean senior managers, I mean frontline staff, and I mean those who line manage staff as well. And this is incredibly important. So what we do as part of our work is we audit existing mental health policies and practice. What do organisations say about mental health? What do they need to say about mental health? Where is the gaps in knowledge and understanding and in policy, for particular instance around absence, for example? And then we focus on how do you recruit and retain people of determination with mental health conditions. That's the application process, the interview process, and then the onboarding process that goes with recruitment. And where you have individuals in your organizations who are now disclosing that they have mental health conditions, how does the organization support those individuals in order that they can remain in employment? And the training of key staff is fundamentally important in terms of both mental health awareness, identifying the kind of signs that would enable organizations to determine that this individual may have issues that need supporting. And we see that very much with targeting the hiring managers within an organization and the line managers as well. But it's more than that. It's about access to resources. We need to bring to life examples where people of determination with mental health have succeeded, have contributed, and have added value to the organisation for which they work. And we do that through case studies, and we do that through good practice guides. And for us at Purple, it is really important that we leave a legacy. And all the work that we do, we strongly encourage as part of our work a training the training package. And so the hiring managers, the line managers can do the training of tomorrow and doesn't require the support or less support of Purple. And so you become independent, you build your capacity, you build your knowledge, you build your understanding of mental health so you can support existing and potential new employees as they come into your organization. And so what are the key success factors? Well, what we see is in the Purple team and our approach is very much multidisciplinary. And what I mean by that is that our team includes disabled people themselves and those with mental health conditions, those with lived experience who can kind of share their stories and have empathy and understanding with what the participants are going through. And that's incredibly important. But they work alongside qualified professional trainers who know how to turn learning outcomes into action, who know how to provide the skills that are needed, that once people have been on the program, they are then able and then ready to go into the workplace. And we support and we utilize other medical experts. Sometimes they're doctors, sometimes they're physiotherapists, occupational therapists, and in this context, it could well be psychiatrists as well, in order that there's a holistic approach to supporting these individuals and giving them the best chance of being able to succeed. Another key success factor for us is that we provide a blend of learning approaches. And that's very much about classroom-based, or was about classroom-based teaching and learning. Increasingly, that's now online, but that has been shown to be an effective learning environment if it is made accessible. But every individual that comes on the programs are unique, and that requires a unique bespoke solution. And so coaching, one-to-one coaching, is incredibly important, as is small group sessions, because it's important for others to share their lived experience of mental health with the group, so they know they're not alone, they know they're not unique, they can learn from their peers just as much as they can learn from the training program. And I think what is unique about this program is that we look at it through the lens of both the employee, the person of determination with mental health conditions, and what their needs are, what their wants are, where the gaps are, the pace in which they need to be supported. But we also see it through the lens of the employer, and that if this is to succeed, then the employer needs to be confident, they need to be comfortable, they need the resources in place, they need the training in place, they need staff to have the level of awareness. And from the very top down, there needs to be a commitment to have an inclusive culture within the organisation as part of their organisation and of their brand. And within the UK, there is access to some government funding to support the implementation. For a lot of organisations, they've realised that actually the support required is no cost or very low cost, and have done it themselves. But there are, in some cases, a need to access pots of money and some funding to make sure it is, one, a success, and two, is sustainable. And success increases interest and involvement. And what we see is a kind of snowball effect, that once you make it work somewhere, then other people are more encouraged to run the program. Because what is absolutely clear, that as organizations, as communities, we want to be inclusive, and we want to enable individuals of determination with any kind of impairment, whether it's mental health conditions or being a wheelchair user or sensory impairments, to contribute and be a part of wider society. And it works. And it works. We have shown that running the program has had a positive impact, and it has got individuals into employment, and not only into employment, but staying in employment as well, which is incredibly important. And I think, just to close, some takeaways for you. In terms of the world we're all currently living in at the moment, the prevalence of mental health is simply going to increase. And that will be by individuals who have never been touched by mental health before, having mental health condition, which may fluctuate, which may be permanent. And it will also mean that people who have had and who are having mental health issues and have had for a while might decide that this is the time to disclose and talk to you about their conditions. So we know that the numbers will increase. We also know that employers want to do the right thing, but for many cases, it's just having access to knowing what is the right thing to do and how to do it. And when that is provided, it then gets done. And we know that 50% of the workforce, 50% of people in your organizations will either have a disabled relative or someone in their close network who is disabled. So your staff will really want to support this initiative, will really want to provide support and peer support to individuals. So overall, this is a win-win for everyone. At this time, it's incredibly important that we do all we can to support people of determination with mental health conditions. Thank you for listening to me. Thank you for my time, and I hope you enjoy the rest of your conference. Thank you.
Thank you very much, Mike, for the talk. I think it's inspiring to see how employment could offer people with determination the right thing to do, and I'm sure that we will have a lot of questions with regard to that aspect. Now it gives me a great pleasure, honor, and delight to introduce my colleague, Dr. Deepak Thalitaya. Dr. Deepak is the lead for Intellectual Disability Clinical Academic Group at Al Amal Hospital. He works with the Maudsley team. He has 20 years experience in clinical leadership, research, academic areas as a consultant psychiatrist in the UK. Dr. Deepak has held roles as a training program director with schools of psychiatry in Cambridge and West Midlands, as well as medical schools, nursing and social workers, education, further education in different parts of the UK, including Cambridge, Warwick, and Buckingham. Dr. Deepak is proud to be the recipient of 3 NHS Excellence Awards that are only awarded for clinicians of the best caliber in the NHS. Working with Dr. Deepak, he has a reputation of being so passionate about giving the best care possible for his patients. He will be talking to us about the impact of the epidemic on the vulnerable forgotten. Dr. Deepak, I look forward to hearing your lecture.
Good afternoon, everyone, and welcome to day 2 of the conference. Thank you very much for the kind introduction. My name is Dr. Deepak Thalitaya, consultant psychiatrist at Maudsley Health and head of intellectual disability psychiatry at Al Amal Hospital, Dubai. 2020 has been an exceptional year, unfortunately for all the wrong reasons. COVID-19 pandemic has dominated world headlines and affected millions across the globe, across all spectrums of life. Whilst the pandemic continues to plague the world, highlighting the challenges for governments, people, and environment alike, little is known or indeed has been said about the impact on what I describe to be the vulnerable, forgotten, those with intellectual disabilities. I would like to spend the next 20 minutes or so talking about how the pandemic has affected this group of people and what we can and should we be doing as professionals to safeguard people with intellectual disabilities. So the most recent statistic as of November 11th, cases 51 million, deaths just over 1.2 million. So significant impact on the global population. Very quickly, intellectual disability, we all know what's all about, but really somebody with an IQ below 70 with socio-adaptive functioning deficits present from early childhood. Statistics show there are about 1 billion people around the world with some form of disability. 1 in 7 of us have some form of disability. More than 80% of them live in developing countries, and more than 50% cannot afford healthcare. In the UAE, in 2017, propagated a policy for empowering people with disabilities and called people with disabilities people of determination to reduce stigmatization and create an inclusive environment that fosters growth and well-being in recognition of their achievements. UAE aims to become the world's friendliest place for people of determination, issuing many legislations to protect their rights and provide them with internationally benchmark support. For me, really remember, everybody with a disability is a person first, and each one has an individual profile of strengths and needs. Right, so now let's talk about COVID and why is it worse for people with disabilities. Now, as I said before, there's a lot of media information about COVID and the impact on different groups of people, but very little on people with disabilities. So let's talk about the physical health first of all. I mean, this is a physical illness, but I want to highlight the underlying physical health issues in people with disabilities. Now, people with disabilities have a higher rate of comorbid physical illnesses and lower life expectancy. And we know that in the COVID pandemic, one of the key targets were elderly people who were entitled for COVID-19 testing. However, this group of people were not initially. Studies have also shown that respiratory infections are the leading cause of death, especially among those with Down syndrome. Therefore, COVID-19 may actually exacerbate existing illness, and people with disabilities may become very ill and unable to benefit from intrusive treatment. We also know that obesity is also higher in people with disabilities, which risks severe COVID-19 infections. So really a mixture of physical comorbidity, social circumstances, personal habits, and limitations and understanding all play a role in having impact on the physical health of people with intellectual disabilities. We also know that they can suffer a precipitous decline if they develop a violent infection. Sometimes health issues can be overlooked and diagnosis can be delayed, as new issues are assumed to be because of the disability rather than a new condition. We also know that people with disabilities live in a range of settings, and infection control can sometimes be a challenge in these kind of settings as well. A study in 2010 by Gimenez spoke about H1N1 infection in institutions for people with disabilities and showed that there was a high mortality amongst residents due to the low level of vaccination and carers as being vectors of infection. Coming to the mental and social aspects of this group of people, we know that mental disorders are higher in people with disabilities. Many people live in communities. Now, we know that with the lockdown, this has had a significant impact on their general well-being, and they feel cooped up, which results in significant distress and challenging behavior. There's also a disproportionate impact on disruption to the services they rely on. There's also impact on financial and employment. Closure of services and reduced workforce have also played an impact and role with reduced education, day center activities, and so on. There are also barriers to accessing public health information, hygiene measures, but also the cognitive ability may actually hinder their adherence to public health measures. We also know that breakdown of care, routine, and lockdowns can increase anxiety and behavioral problems, but there's also the stress of contracting COVID, social distancing, and quarantine measures, which can also increase stress levels. Information overload also can play a role in triggering stress and anxiety and paranoia, leading to behavioral challenges and mental illnesses. We also know that COVID-19 now can actually compound the need for scrupulous personal hygiene, and this can be worse in people with OCD, autism, and people with disabilities. There are also issues around behavioral psychological interventions which cannot be implemented because of reduced face-to-face working, and also this group of people will need updated behavioral plans and formulations. Families actually have a need for extra support, without which the risk of breakdown is high, which can potentially lead to hospital admissions because of increasing challenging behavior. One thing I'd like to highlight is that of diagnostic overshadowing. It's very important to delineate and make sure we are clear on what is mental illness and what is a behavior because of environmental changes. Okay, now let's look at the impact of PPE. This has been a key topic for the last few months. What's the impact of PPE on people with disabilities? Now we know that all the coverings can actually disrupt verbal and non-verbal and facial expressions. And this can actually increase anxiety because it's a visual change, and people with disabilities can often find change very difficult. So some things I think are useful for us as staff is to make sure we use eyes and natural gestures, facial and body language to facilitate positive communication, using signing or symbol-based communication, using and taking support of families and carers who know the patients very well. Also using slow, clear speech, allowing enough time, and using visual aids where necessary. Now, looking at the COVID-19 impact on carers looking after disabilities. Now, we know that many people with intellectual disabilities live with elderly family whose health is often compromised. And they often require high level of support from carers, which increases the social contact as well. There have also been disruptions with PPE access in the first few months of the COVID-19 pandemic. But also carers and family can often feel let down with access to PPEs, or indeed the ability to skill or have the skills to look after people with disabilities who are infected. It's also important to look at the need to acquire new skills to support this group of people who are suffering from the pandemic. We also know that barrier nursing and infection control can be a challenge in this group of people who may not understand the importance of adhering to infection control and hygiene measures. There have also been impact because of less staff for services, because of illnesses, isolation, and so on. Another thing to highlight here is the behavioral challenges. Sometimes things like spitting can actually pose an increased risk, particularly in COVID times. So now let's look at the fatality rates in this group of people. There are a few studies now over the last few months across different countries, particularly the UK and US. I will draw your attention to the graphs there, all of which, now the first slide is a study in 2017 looking at pneumonia death rates and significant increase in people with disabilities compared to general population. In 2020 with COVID-19 pandemic, again, a significant increase in mortality rates in people with disabilities, particularly in the younger age group, 18 to 74. More studies in the last few months which really show a much significantly higher rate of mortality and death rate in people with disabilities. Right, this is just hot off the press. Just a few days ago, a study looking at the impact of COVID-19 on individuals with Down syndrome. Down syndrome, is, as we know, is one of the most commonly recognizable cause of intellectual disabilities. This study showed that the symptoms and signs were almost similar to those with the general population. However, pain and nausea were reported less frequently, and this is perhaps speculative because of the communication limitations. However, altered consciousness and confusion were reported more frequently. Risk for hospitalization and mortality were similar to the general population, with particular regards to age, gender, that's male gender, diabetes, obesity, and dementia, for example, with addition of congenital heart defects. However, mortality showed a rapid increase from the age of 40 as compared to the general population, and the relative risk was ranging from 2.9 to 3.5. So that's much higher risk of mortality from the age of 40 as compared to general population, which is in the elderly ages after 70, 80 years of age. So now let's look at some of the responses to the pandemic. Various organizations have set about using easy read information. Inclusion Europe have submitted a petition to defend the rights of people with disabilities during the pandemic. There was a NICE guideline, NG159, which spoke about the clinical frailty scale to assess a person's suitability for invasive medical treatments, recommending that priority should be given to people based on the dependency scale. So people who are highly dependent in daily life would be the first to be denied intensive care in case units became overwhelmed. This was challenged, as understandably so, but I think it badly damaged confidence among people with disabilities. Financial incentives obviously is something that is quite important as well. Again, this is hot off the press. NHS England and NHS Improvement in the last few days have issued a directive stating that all adults with Down syndrome have a higher relative risk of mortality and morbidity and should be identified and reviewed by practices for inclusion on the shielded patient list. So what should we be doing? I mean, first of all, taking it seriously, reducing potential exposure, maintaining physical distancing and working from home where necessary. The caveats around shielding, isolation, testing, tracing, sanitizing, PPE remain as prevalent as they are now as they were from day one. Teaching and supporting people with disabilities to maintain regular hand hygiene. But also it's about now maintaining continuity plans, contingency plans as well, ensuring we have the right emotional and practical support, regular communication, maximizing the use of technology where possible, and also making use of support from government, statutory and non-statutory organizations as well. It's also about making sure there is accessible, adaptable public health information available, and inclusive and affordable healthcare for everybody, and upskilling the health care workers where necessary as well. I would be amiss to not talk about carers and family who remain a vital part of the health of people with disabilities, both in the community as well as in healthcare systems, but also in ensuring that we coordinate between health agencies, social services, families, and caregivers, addressing any physical barriers, attitudinal barriers, financial barriers that may exist. Also as clinicians to remain vigilant to changes in presentation. So for example, people with disabilities may not be able to report they have a headache, but some things like a cough are very observable, and to be alert and vigilant to these as well. I'm going to talk a little bit about psychiatric inpatient service planning. I think from an inpatient perspective, I think it's very important to look at issues around risk rating, making sure we have the right systems around cohorting and bubbling patients where necessary, making use of robust handovers, effective team working, upskilling staff, which is very, very important as well, making sure staff are supported and having enough and more PPE where necessary. Again, maximizing the use of technology, reducing duplication of work, but also increasing activities in hospital to replace anything that has been discontinued. But also it's very important to look at supporting safe discharge where safe and clinically appropriate. And I think it's very important to remember that people with disabilities live rewarding lives, and disability should not be used as an excuse for do not resuscitate guidelines. It's also important to look at advanced care planning to prepare for serious illness, to reduce suffering for those close to end of life. Now, looking at psychotropic medication. Now, we know that people with disabilities are generally prescribed psychotropic medication. COVID-19 may actually increase the reliance on medication, contrary to initiatives such as STOMP to reduce the use of psychotropic medication. So for us as clinicians, it's very important to make sure we review medications in line with good medical practice, using electronic records where possible, avoiding overuse of medication, watching for side effects such as respiratory depression, cardiac effects, and so on, liaising with family doctors and pharmacists to avoid any disruption to medication, using technology where possible, and reviewing positive behavior plans to minimize use of medication as much as possible. Now, let's look at some of the personal experiences. These are some of the things I picked up from various sources, and some of the key words that come across here really are being forgotten, without the right equipment and resources, feeling a tipping point, being vulnerable, not being able to go out, the never-ending pressure, and you know it's never going to go away, the need for practical and emotional support. And I think this last couple of ones, unless you have a disabled child, you will never understand how it affects life. And this is 10 times worse because there's no let-up whatsoever. Another person talks about how they're feeling scared because the talk is mostly about the numbers and the death rate, but not so much about people that survive. So whether we need to try and think of alternative ways of sending the right communication. So really, this is just a very visual or graphic description of trying to make it easy for people to understand what's going on and seek help and support where necessary. Again, just talking about the COVID red flags, we know the common things are around cough, high temperature, and so on. But some studies have shown that altered consciousness or onset of new confusion or worsening of challenging behavior can actually be a sign or a potential sign of COVID-19 in people with disabilities. Some other additional potential risks in this group of people include dysphagia, gastroesophageal reflux, epilepsy and seizures, or obstructive sleep apnea. So it's important for us as clinicians to make sure we have regular physical health monitoring using standardized and validated instruments. If there's any doubt, discuss with clinicians as necessary. Very quickly about capacity and law, it's very important to make sure that this group of people are well informed with their the conditions, what's going on, and prompting best interest decisions or discussions where necessary, and it's very important not to contravene human rights. Very important to ensure that we balance the rights, autonomy, and well-being. In the UK, for example, there's health protection coronavirus regulations, which actually allows authorities to prevent people from leaving homes without reasonable excuse. And in systems and countries where there's mental health legislation, it's very important to make patients, families aware of changes to mental health legislation, apply good practice, and so on. Looking at safeguarding, this is again very important. Abuse in general is very high among people with intellectual disabilities, and there have been several serious incidents over the years. But having said that, we also know that domestic violence in the general population has actually increased during the pandemic. And this should actually alert us to the potential of greater risk to people with disabilities. We need to identify the potential for increased violence, abuse, neglect, isolation or disruption, and we need to do everything we can to support and mitigate any of these risks. Also, the reduced face-to-face contact may mean that there's fewer opportunities to gain a sense of patient safety, and we may have to rely on a greater reliance on technology to conduct safeguarding interviews and so on. This is something I've drawn up as an example of a COVID-19 care plan, which I think is very important for patients to carry with them, almost akin to a health passport of some sort. So really giving a very snapshot description, picture of the person's circumstances, the basic issues, the condition, diagnosis, medication, the support systems they have in place, and any action that people are doing to try and support them during this time. This includes contingency and continuity plans as well. So I think whilst I'm talking about people with disabilities and the families and care, I think it's very important to ensure that we do not forget how this also has an impact on staff well-being. So we know over the last few months, the impact on healthcare workers, the high morbidity, high mortality, there have been significant pressure due to environment changes, uncertainties, and lack of contact with families. But there is actually very little data because the last pandemic took place about 100 years ago. So there is little data on psychological effects on staff well-being as well. Some studies have shown that there's a high rate of traumatic stress, which is amplified by the quarantine or isolation. Healthcare workers feeling traumatized, isolated, abandoned, and actually feeling scared for themselves as well as their family at the time of uncertainty. So there's also the impact of stress, pressure, and burnout on this group of healthcare workers. The WHO recommends basic principles around training healthcare workers, ensuring PPE, psychological support, hospital surveillance, and also ensuring that any gaps are recognized and addressed. What we've done here at Amar Hospital is to introduce Balint groups for the resident psychiatry doctors. We know that there's a paucity of literature on Balint under these circumstances, but the potential psychological benefits have been unexplored in a mental health organization, particularly in the Middle East in the time of COVID. Historically, we know Balint group tends to increase coping ability and psychological mindedness. It's an opportunity for doctors to reflect on work in a safe, supportive setting, gives an outlet for stresses and frustrations, and fosters team spirit and cohesion. This also promotes diversity of thought with ethical and COVID-19 problems. We are hoping that this would improve job satisfaction as a result of the group discussion and prevent burnout, which is even more poignant at the time of COVID-19. So really, last few slides from me is the lessons to be learned. I think for us, or healthcare professionals looking after people with disabilities, it's very important to ensure that there's a up-to-date register with anybody who might be at risk of COVID-19 and also having a intellectual disability, looking at those who may be at risk of placement breakdown or those without specific support needs. It's very important to ensure we have a good understanding and oversight of the local, regional, and national capacity of specialized services to tap into where necessary. Working closely across organizations and authorities is going to be very, very important. Access to testing and PPE remains as strong as it is today, as it is from day one. Ensuring we invest in appropriate MDT interventions, making use of adaptive technology, ensuring staff are skilled, there's proper training and awareness to prevent discrimination and reduce any bias that this group may potentially suffer from. Promote mental and social well-being, capacity building program, ensuring that the new generation of medical students, nursing students, and so on are having the right training for looking after this group of people as well. Making sure families and families and carers are supported as well with support groups. Making sure there's right support from a financial perspective as well. But at the end of the day, also making sure, this is still very early days, making sure we have frameworks for robust research and experiences of COVID-19 in this group of people to understand the impact on their lives and how they have coped. So future pandemics and the unknowns. So now, like I said earlier, the immediate effects of pandemic are virtually unknown because there's very little data. The social impacts of the pandemic are becoming slightly apparent, but what are the long-term consequences of this on health? Well, we don't know. How will people with disabilities adjust to new practices with fewer face-to-face meetings and more reliance on technological communication? Again, something to think about. A study by Zeng in 2020, earlier this year, spoke about neonates testing positive with COVID-19 and recovering. But what are the potential long-term developmental impacts on fetal development? Will there be consequences on fetal development like the Zika epidemic? Something again to think about. So really, final thoughts for me, COVID has been and is the most pressing current world crisis, has had devastating, profound effects on populations worldwide, globally infected and killed many thousand million people, and testing the healthcare systems of countries. Whilst we know that vulnerabilities around the elderly or those with comorbid health conditions are recognized, the limited testing, reporting of COVID-19 in people with disability, the social disadvantage, the income disadvantage, disparity in healthcare provision, physical and mental health comorbidity, all means that this group of people are at higher risk of problems because of the COVID. So I think we have to act as advocates to ensure that we protect this group of people, not just from the infection, but also how we support them in their life during the pandemic. So governments, social and healthcare organizations have an important role in addressing this group of people and carers. So really vulnerable people with intellectual disabilities may be forgotten as the pandemic unfolds, and our responses should not neglect or exclude this group of people. And people with intellectual disabilities should be a priority in any planning for future pandemics, not just for COVID-19. So really my view really is that those who need help should get help when and where it is needed in the way that is needed. These are some of my references. So I'm going to end here with the final thought really that I hope that the pandemic will lead to better care for people with intellectual disabilities, not just now, but also in the future. Thank you very much for listening. I welcome any questions in the Q&A session. I hope you all enjoyed the rest of the conference and have a lovely day. Thank you.
Good afternoon again, everyone. Thank you, Dr. Jigna, Mike, and Dr. Deepak for the valuable information and the passion you projected about disability and patients in general. I particularly liked Mike adopting the UA term of people of determination instead of people with disabilities. That gives them the value of what they endure to achieve what they achieve. So I particularly like that. We have a few questions. So I have a question for Dr. Jigna, especially about really how did you keep inpatient safe and mental health services in the UK during the period of COVID-19?
Yeah, it's a tricky situation. We generally, in the UK, a risk assessment is done as soon as a patient is admitted. I guess the tricky situations with patients who are not known to mental health services, we don't have as many parameters to form a full risk assessment. So we can only go on what we can see with the patients. In terms of COVID-19 as a whole, the mental health hospital is separate from the general hospital, so therefore cases are not generally mixed. New admissions are kept isolated in their own rooms until a PCR swab result has returned negative. If they are found to be positive, they're moved to what we created as a hot ward. The patients who with positive results. If they were negative, then they were allowed out onto the open ward. However, overall, all of the inpatient units are generally locked anyway, so the patients are only able to leave the ward once a risk assessment has been done and out for either with a member of staff or for certain tasks. During the pandemic, the other thing that was I guess closed was visitors. We were not allowed visitors for the patients, which was very, very difficult. The patients were also not allowed food deliveries and takeaway. So it was a very, very closed environment. The gyms in the hospital were closed. Which meant the nursing staff and the occupational therapy staff were challenged on activities and keeping the patients engaged, and also helping with recovery. It did make it very difficult. A lot of the patients were very frustrated. However, we kind of saw like a sense of banding together. So all the patients were kind of, took this understanding that they were in it together. They were helping each other out as well. Also, I guess modern technology was quite helpful. FaceTime and things with friends and family was very useful. We introduced a ward kind of iPad which patients could use if they weren't able to, if they didn't have credit on their own phones and things like that. So they could use that phone to FaceTime their family and Zoom things like that, which was quite helpful. And so the nursing staff were assisting patients in doing that as well. So it was very, very tricky during the initial lockdown period.
Thank you, Dr. Jigna. Thank you. The other question I have is for Dr. Deepak, and I drew some similarities between my patient, I'm an old-age psychiatrist, my patient and your patient. I'll tell you why that question, because I had a lady who always we diagnosed as being depressed, and after the COVID, after the curfew, and after people started staying at home, miraculously, all of her depressive symptoms disappeared. She was very happy with her children being around her. Apparently she was lonely. So can you see any silver lining to the COVID with regard to the people of determination or intellectual disability patients? Have you seen that thing? Have you seen that any positive impact of COVID on patients?
Thank you, Dr. Tariq. I think that's a very interesting observation. I certainly have not seen that in the UAE, but I have heard anecdotal evidence from my colleagues in the UK. And I suspect that perhaps because of a lot more robust social care mechanism in the UK, where there's a lot more expectation, where they have to go out, engage in activities and so on. And some of my colleagues in the UK have actually commented that the fact that they didn't have to go as regularly as they had to normally gave them some breathing space. So they could actually sit down at home and, within their care homes and so on. And they were a little bit more relaxed. Having said that, that is anecdotal. I have not seen that evidence in the UAE. And I think the demographic profile in the UAE is obviously very different as well. And not to mention the social support, again, quite different. So I think in terms of positive lining, it's a very good question. I think, as Dr. Jigna said as well, there is a sense of this coming together in some way, that we're all in this together. We need to get through it together as well. So the families which are a lot more cohesive, that's the positive, certainly a big positive in the UAE. We know that families live together in joint families, large numbers of support systems within homes as well. So that certainly is a very positive step in the UAE, which I don't think exists in other places. So there are certain positives for sure. There's no question about it. But how long can it be sustained? I think it's a matter to be seen over the course of the next few months.
Thank you, Dr. Deepak. Mike, I don't think that really changing the vision of from charity and people receiving benefit to adding valuable to the workplace hasn't been easy. And I don't expect that to be easy here either. So just how to deal with the repeated frustration of not being able to change the vision and the culture of the place. So to draw on your own experience as an advocate for people with determination.
Thank you very much. And I absolutely understand your point. And it is a long journey. And I think what COVID-19 has done is really shine a light on the you talked a bit earlier about the isolation and the loneliness of individuals. And I think COVID-19 has increased that in some ways. And in your example, has made it better in terms of the family and stuff. And I think what transcends all of this is the emerging digital world and the ability for online accessibility, because that's going to be the connection with your community, with your shops, and with your employees and employment. So I think it's a long journey. Cultural change takes a long time. And here in the UK, what we have tried to do is to support employers and get employers to recognize that employing people of determination adds value to the organization. It's good for the organization. It's good for colleagues who work with people of determination. We know across the globe that 50% of people who work either have a disabled relative or someone in their close network. So there's a resonance of disability with the workforce, and it's good for the community and it's good for society. So there's all the reasons why we should be doing it. But as you said, it is this challenge about how you change the culture of seeing disabled people as vulnerable, as charity, as needing welfare support, and moving that to see them as having a contribution and a value to the communities in which they work and in which they live. And the work that we've done is around the disabled consumer, the purple pound or the purple dollar, which is the consumer spending power of disabled people and their families, and how you ensure that those disabled people and those families get a good customer experience. Because if you do that, you then unlock a relationship with the organization to see disabled people as people of determination as consumers. And then really good organizations will want to reflect in their workforce their consumer base. So it becomes a different kind of driver in terms of why disability becomes important. And we're on a journey, but we're getting there.
Thank you very much, Mike. I think the conversation has been enjoyable to the degree that we have run over our time. Thank you very much, Dr. Jigna, Mike, and Dr. Deepak. I thoroughly enjoyed the presentation. I'm sure that our attendees have enjoyed it too. Thank you. I look forward to seeing you well all. Again, thank you.